It was actually a challenge because we wanted to acknowledge that geriatric assessment could serve many purposes, and actually there are so many domains of geriatric assessment, so many different professionals that do it. Each domain and each person who does geriatric assessment could talk for hours about it, and we wanted to just give a flavor of some of the different roles that geriatric assessment could play. We also wanted it to have a multidisciplinary flavor and also an interprofessional flavor. And so one of the sessions was about geriatric assessment in the emergency department and how that could improve care for older adults who are potentially being hospitalized or discharged home. And then another session was about the assessment of polypharmacy and mobility and the interaction that medications play in fall risk. And then another session was about the intervention of physiatrists and occupational and physical therapy and those disciplines on doing rehab interventions in patients who have mobility impairment and fall risk. And really each session, I'm sort of giving it a very brief overview, but they really did a deep dive in those areas. So we wanted to accomplish that. Well, I think we increasingly recognize that multiple different types of professionals and types of disciplines do geriatric assessment. And we've long said that there will never be enough geriatrician physicians for all of the older patients that really need our care. And to be physician-centric is not realistic moving forward. Our panel actually, we didn't necessarily have that good of a spread across other disciplines per se, but each of the panelists really recognized the role that all of their interdisciplinary team plays. So at many institutions, people will use lots of different types of professionals to do parts of the geriatric assessment. So we also wanted to capture that. So each of the speakers captured the fact that their teams work together to accomplish these assessments. The discussion of geriatric assessment in the emergency department was excellent, and it was a little bit of a surprise to see that the interventions were really focused on the older people who were potentially discharged home to help avoid readmission. Sometimes we think about the need to be involved in the care of older adults when they're being hospitalized, but this is really an intervention all about helping older people be safer once they're home. And I think that one thing that came out of that first talk was the uptake of that and the support of the institution and the colleagues. We all marveled that Dr. Shivali had managed to have this service where geriatricians are doing assessments in the emergency department, and for people who admitted they're having a geriatrician involved. And I think some of the question that came out was how did that really happen? How did he influence people to do that? But he acknowledged that it's taken him several years, and we all see that. It takes us a very long time to integrate our services into other specialties. So that was what came out of that, was that it's an impressive collaboration with the emergency department. And I think with Dr. Wild's presentation, the idea that medications and fall risk are integrated was really the highlight, that we sometimes wouldn't think about assessing polypharmacy and assessing falls in the same breath. But Dr. Wild's research has shown that anticholinergics and benzodiazepines and other high-risk medications, but particularly those classes, are significantly important to assess and reduce in order to improve fall risk. So she made that case excellently well, I thought. And then Dr. Pergolati really showed that it's beyond just simple, we often just send people to physical therapy. We think we're doing everything that they need, but she really showed the wholeness of patient-centered care and the various aspects of caring for a patient through a case presentation that she gave, and really showing the different types of interventions and the complexity of interventions that she leads. And I think that was a bit of a surprise as well, even as a session planner. So there was a lot of richness to her presentation. I think that every year we probably could have 8 sessions on the many faces of geriatric assessment. I think that we're always going to be at risk of excluding a domain that people find is very important to them. And we also need to be as inclusive as possible about having multiple different people present their take on geriatric assessment and interventions that are guided by geriatric assessment. So I really hope that this session has positive feedback, because we really could be building off of this in future years.